Hello, good morning. I'm Ashok Kurokade, consultant rhinologist and anterior skull-based surgeon from Winchester and the University Hospital Southampton, UK. I welcome colleagues from around the world on behalf of our organizing team to this inaugural Winter Global Rhinology Endoscopic Sinus and Anterior Skull-based Surgery Webathon. Global Rhinology Network is a registered non-profit organization with a mission to foster surgical education in rhinology and skull-based surgery. We have successfully hosted annual multi-center live surgical webcast, The Lioness, since 2014 in collaboration with Lion Foundation. Thousands of surgeons from all corners of the world have benefited from it. More than 2,000 surgeons from 110 countries have registered for GRACE 2020. We will have hugely informative and engaging sessions presented by eminent rhinologists and skull-based surgeons from around the world. GRACE 2020 is hosted at the Global Telemedicine Studio of Professor Wilco Groneman in Utrecht in Netherlands. It is supported by Medtronic and Karl Storz. Thank you.
Imagine, what if you could do even more to bring relief to your chronic rhinosinusitis patients with technology customized to your unique clinical and facility needs? Introducing Stealth Station Flex ENT Navigation System, a customizable system from Medtronic ENT, a market leader in image-guided surgery technology, featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options, with flexibility in hardware design and optional software functionality. Get everything you need and nothing you don't with Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
So can I invite Claudio to host Phil?
Thanks, Ashok.
Thank you.
Well, I'm happy to present Dr. Phil Chen, who actually is a very good friend of mine. Dr. Chen is Associate Professor at the University of Texas in San Antonio, where he's actively involved in teaching. Also a student and resident. He's actually the director of the residency program in his department. And after training in the US, he did an advanced endoscopic sinus and skull-based surgery fellowship in Australia with Professor Wormald. And today, Dr. Chen is going to present us about optimizing the surgical conditions. Thank you very much, Dr. Chen.
Thanks, Claudio. It's good to be here virtually with you all. Obviously, wish we could be together personally. Certainly want to thank all the organizers for having me speak. It's a real honor to share this virtual podium with such an illustrious group of rhinologists. And of course, I thank everybody for being here, no matter where you are in the world. It's early here in the United States. I'm a consultant for Stryker, Medtronic, and Integra. So surgery is stressful. No matter how long you've been doing this, the reason why you're even on this conference is because you're trying to become better. And no matter how many surgeries you've done, there are parts of it that can be stressful. And we want to make it as little stress as possible, since the disease itself can be challenging. But we know that bleeding makes surgery even more stressful. You can't see, you may try to rush, you may try to hurry, and as a result, your level of stress continues to increase. And so if there's no more important slide that I can show you than today, it's this one. If you can't see, you can't operate. You're learning amazing information today from multiple surgeons around the world, but everything they teach you about surgery is not going to be applicable to you if you can't see what you're doing. We know from research that the risk of complications goes up as the bleeding goes up. So hopefully today you can learn some tips about anesthesia and about what you can do to decrease the bleeding during your surgery so you can do the best surgery you can for your patients. I want to break this down into preoperative surgical factors and anesthesia factors. Now, this is going to be very quick. I don't have time to go into all this in detail, but you all know that we want to decrease things such as NSAIDs and anticoagulation. But as an otolaryngologist, you may not always think about wanting to decrease more systemic problems, more medical issues. As surgeons, we oftentimes focus on the surgical problem. And one of those things specifically, I would say, is hypertension. If your patients are hypertensive when they see you in the office, that's not going to suddenly get better when they go home. And when they're anxious on the day of surgery, that's going to get even worse. And so that's going to prevent the anesthesiologist, which we'll talk about later, from dropping that pressure to a place that's going to help you to have less bleeding during your surgery. And so really, if they're hypertensive during your clinic visit, make sure you talk to them about that. In addition, supplements. We know online there's plenty of information that patients look for. And there are at least 60 different supplements that are thought to increase bleeding. And I can't remember all of them, so I simply tell my patients to stop all of those supplements. And finally, steroids. We know about steroids, but what we don't think about often is that our patients tell us, well, those don't work for me anymore. I've used them for years. The reason I'm here to talk to you about surgery is because of these not working. But there are studies that suggest that even topical steroids used for more than 4 weeks actually helps to decrease bleeding and decrease operative time during your surgery. So I encourage my patients to stay on this, even if they don't feel like it's helping specifically. Especially for patients with polyps, we know that systemic steroids is also helpful, but during the COVID-19 pandemic, we do have to weigh the risks and the benefits of a weakened immune system. Okay, so now let's get into the real details of what we want to talk about today. I want to break this down into surgical factors that you do as the surgeon, and then anesthetic factors of things you can talk to your anesthesiologist about in order to get the operative fields that you most desire. Now, I want to pause for a moment here and talk about working with your anesthesiologist colleagues. Remember that we have the same goal, which is taking care of our patients, but we see things from a little bit of a different perspective. We're looking at the sinuses or the head and neck area, whereas they are focusing on the physiology of the patient and keeping them safe. But at the end of the day, our goals are the same, and so we need to communicate with that with them. Now, throughout my career, I've run into individuals who may have been reticent to perform the types of anesthesia or maneuvers that I ask of them. And I was really wondering why that was the case. So we set out to do a survey of anesthesiologists across North America. And I think this is an important slide because I am here to tell you we need to work with them. This is not to say anything bad about our anesthesiologists. But when you look at this survey across North America, you see that many of them just don't do much in the way of FESS cases. In this bar here, you see that most of them do fewer than 5 cases every month. So as a result of that, they just aren't particularly familiar of some of the interventions that we like, such as total IV anesthesia. It's not that they don't want to do it, they just don't understand necessarily why. And so whether it's TIVA or whether it's the use of topical anesthetics, you see that they just are not particularly familiar about our literature on this. So you can be helpful in sharing that information with them. You can educate them, you can bring them the studies so that they can work with you in a collaborative fashion. So the first thing that we can do as surgeons is apply topical vasoconstrictors. There are multiple on the market, whether it's oxymetazoline, phenylephrine, cocaine, and epinephrine. And all of these are probably reasonable options. In my hands, I just haven't found that oxymetazoline works quite as well. Now, there are studies that may disagree with me, but I personally don't find it to be as effective. Cocaine has its risks. It's hard to get in certain parts of the country, and so there's a lot of paperwork, so that may or may not be beneficial to us. Epinephrine 1 to 1,000 has been shown in multiple studies to be rather safe. It's an excellent decongestant. It helps with hemostasis. The complication rates for healthy patients is extremely low, and even for patients who may not be 100% healthy, oftentimes as long as their physiologic parameters are controlled by your anesthesiologist, you can keep the patient rather safe. But there is always that concern about systemic absorption, even of this topical medication. There's a small percentage of patients who actually are hyper responders to this. And so their blood pressures skyrocket when you put this in topically. So be sure to communicate with your anesthesiologist that you're placing these medications into the sinuses so that they know to expect this, even though it's a relatively rare occurrence. Obviously, those with cardiovascular disease and preoperative hypertension you want to be careful with, and also children and slight patients are not those that I use this medication in. Now, there is that discussion about the topical absorption, and a nice study was actually done by the Sydney group where they didn't see much at all topically, but when there was an injection of the local vasoconstrictors, such as epinephrine or adrenaline, then that's when they actually saw the changes. And so I discussed that with my anesthesiologist as well, that most patients don't have significant systemic absorption. Where do I place these? 3 places. I place a cotton pledget medial to the middle turbinate. That's helpful when we are working on the sphenoid, the lateral to the middle turbinate for the ethmoid and the frontal work, and then along the inferior turbinate to add an area for blood to run down to the nasopharynx. And then intraoperatively, if there's bleeding, I place a neuropathy in there and I let it sit for some time. Now, it's really important that when you use this topical 1 to 1,000 epinephrine, that you add some type of dye, whether it's fluorescein or a purple marking pen, to that liquid. The reason for that is you don't want to inadvertently inject this. That could cause significant problems to your patient. And actually, I had a situation where a scrub tech came in to give a lunch break and handed me a syringe when I asked for local. And unfortunately, I had dyed that ahead of time. So I saw that that was a problem and I immediately knew not to inject that. So do things that you can to keep your patients safe. Now, how about those local vasoconstrictors instead of just topically injections? Well, there are 2 places that I think about. One is the greater palatine foramen, so intraorally, and the other is intranasally. We can do injections as well. And per that study in Sydney with the changes in physiologic parameters with injection, I have now switched to 1 to 200,000 epinephrine rather than what's typically used of 1 to 100,000 epinephrine, just to decrease the amount of that medication that the patient is getting. So if we look at the greater palatine foramen, how do we inject that? The nice study done by the Adelaide group some years ago, a cadaver study, they found, as you see in this bottom left-hand picture, a sagittal view, and you can see the greater palatine foramen here and the pterygopalatine fossa here. And so we know we want to go after those maxillary artery branches. And so they found that a 45-degree angle, 2.5 centimeters from the tip of the needle, actually slides very nicely into the through the greater palatine foramen. We use about 2 milliliters of 1 to 200,000 epinephrine, and you can find this intraorally here between the second molar and the midline, and then you can palpate that foramen. Always remember to draw back when you inject this. You don't want to inject this directly into the arteries or the vasculature. You can also inject locally into the nasal cavity, as demonstrated here. And honestly, I do this less and less. First of all, the risk of inadvertently injecting the 1 to 1,000 epinephrine, we don't want that to happen. But in addition to that, some of the systematic reviews and other literature do not show a significant improvement in surgical field with injection. And that makes sense because our injection affects arteries and arterioles maybe, but a lot of our bleeding is capillary, and so this isn't necessarily going to help. But if you do inject, there are a few places I would definitely consider, which are shown here in the X's. I especially like to inject at the axilla for when I'm working on the frontal sinus and on the inferior turbinate to decrease the size of the inferior turbinate as described by Professor Metzen. How about positioning of the patient? A lot of early studies that looked at bleeding and bleeding scores had the patients reverse Trendelenburg about 5 degrees. And we know that actually it doesn't do enough to decrease the venous congestion in the head that we are aiming for. Actually, data suggests that elevation of 15 to 20 degrees is what is needed to improve the surgical field. Now, while that sounds relatively straightforward and easy, if you go to your operating room and actually elevate the head of bed 15 to 20 degrees, you will notice a pretty significant elevation. And that can make it pretty hard for one to surgically access the field. So we actually looked at the operating room tables and operating stools, both those that were available at hospitals in our area and online, the information that we got. And we found that a lot of operating tables just don't go low enough. So if you're a seated surgeon like me, you really need a table that can lower down enough that you can elevate the head of bed and still be able to comfortably work in your range of motion and to maintain your good ergonomics. And so please do look at that when you're in your operating theaters. I really like to do warm saline or water irrigations. This is done at about 49 degrees. You don't want it to be too hot because if you do, there's excess edema in the nasal cavity and that narrows the passage and actually makes your visual field even worse. So you want to be careful that your temperatures are warm to hot, but not too hot. And how does warm water irrigation work? Well, the first thing it does is it decreases blood from our surgical field. We know that blood is red. That sucks up a lot of the light from our endoscope and therefore makes it much harder for us to get a good field. It's dark, it's bloody, it's not very good. But in addition to mechanical clearance, which is helpful, it may improve hemostasis as well. And in fact, saline and warm water irrigations have been studied through many other fields such as OBGYN and urology. Now, how that works exactly, we're not really sure. There's some thought that it may affect the clotting cascade. There's other thought that it may cause a gentle edema of the mucosa to close off those vessels that are leading to blood in our field. But at the end of the day, it seems to decrease blood loss and we can see better. And I really do like having this in my operating room. Suction instruments are also, I believe, very important to your surgery. They don't decrease the bleeding, but what they do is allow you to see your operative field better. Even when there's mild to moderate bleeding, let's say a Bozart score of 3, when you put that suction in, take it out, that gives time for bleeding to come back. Then you put your instrument in there to try to do your surgery and you get frustrated because there's already blood in your field. The surgical instruments allow you to do both the cleaning and the surgery at the same time. In addition, have some cauterization, whether it's, I have both actually, monopolar and bipolar because you use them in different areas and both of them have suctions on them as well. Okay, now let's talk about what we can further discuss with our anesthesiologists and things they can do to help you. Beta blockers are helpful in controlling heart rate, trying to maintain a mean arterial pressure around 65 for a healthy patient, total IV anesthesia, and IV TXA. So let's take a trip back in time to when you were in medical school again, and let's talk about physiology, things we may or may not talk about every day in our practices. In order to decrease the bleeding in our field, we need to decrease the flow. And what is flow? Well, it's related to the cardiac output from the heart. We know that the cardiac output is related to heart rate and stroke volume, if you remember that equation, but also that it's highly correlated with the mean arterial pressures. So ultimately, if we can ask the anesthesiologist to do things that are going to decrease our MAPs and decrease our heart rate, we should be able to get a better surgical field. And if they can also decrease vasodilation, that's like having a dam at a lake that's going to decrease flow into our cavity and into our field as well. So decreasing the caliber of those vessels is beneficial. So let's talk about heart rate first. Beta blockers are actually very, very good in helping with heart rate. And we know that our patients are on them oftentimes for their blood pressure problems. So beta blockers are negative chronotropes. They decrease the heart rate, but actually they're also negative inotropes. They decrease the stroke volume and decrease blood pressure. So that's really nice for us. And in multiple studies that have been performed, many of them were randomized, many of them were blinded and placebo-controlled, there's been evidence of benefit of using some type of beta blocker either before or during the surgery to improve the surgical field. In one study, the patients were given oral metoprolol. This was a double-blinded study, and they found that when patients had oral metoprolol ahead of time, there was a better surgical field than those that were on a placebo pill. In addition, regardless of whether they were in the metoprolol group or the placebo group, there was an improvement in surgical field when the heart rate was lower. Another study randomized as well and blinded was esmolol versus sodium nitroprusside. They found better surgical fields with the esmolol. And that makes sense because sodium nitroprusside, while it does decrease the pressures, is also a significant vasodilator. Another study of esmolol versus placebo also showed benefits of esmolol. And esmolol is expensive and it's very short acting, and a lot of hospitals may not like to have that used as a default medication. So one study that looked at esmolol versus labetalol found no difference in the bleeding fields during surgery. So that's another consideration of a different beta blocker that is somewhat less expensive and still seems to be rather beneficial in the surgical field. Now let's talk about the mean arterial pressures. We want to decrease our mean arterial pressures during surgery, but remember that the mean arterial pressures are a reflection of the cardiac output, and that's critical that we maintain good perfusion to vital end organs such as the brain, the kidneys, the lungs, and so forth. So we can't just drop the pressures as low as we would like. We need to find a safe range where the bleeding is pretty good, and yet the patient remains safe. And so in an eloquent study done by the Adelaide group, they used transcranial Doppler and addressed the flow through the middle cerebral artery. And by doing so, they found that there were points here where you had significant decrease of flow through the artery, and down here around 40 to 60 millimeters of mercury. Now those did have the best surgical field, but it seems a bit dangerous. As you get to about the map of 65, however, you see that your flow is greater than 90%, and you have still a very good surgical field. As you increase the mean arterial pressure, you don't have much benefit as far as flow to the brain, and yet you have worsening field. So you're only frustrating yourself. So this is a good study to show kind of where you want to keep your mean arterial pressures. Now remember that not all our patients are ASA class 1 and 2, which is the patient population in most of these studies. And many of our patients have other issues such as strokes, heart attacks, hypertension. And so it's important, as I mentioned at the beginning, that we manage these pre-operatively to give ourselves the best chance of having a low pressure during surgery. Because as you can see on this chart here, this orange line represents those with chronic hypertension. They have a higher demand and a higher pressure need to perfuse their brains properly. And so be careful on those types of patients to make sure you don't drop them too far, because a map of 65 for that patient may really be harmful to that patient. So how do we decrease our maps? Well, there are two primary types of anesthesia, and any type of anesthesia is going to drop your mean arterial pressure. Traditionally, we've used inhalational agents such as sevoflurane or desflurane, and those, while they do drop the maps, also result in significant vasodilation. Another way of performing general anesthesia is with total IV anesthesia known as TIVA. And this usually consists of a sedative hypnotic, such as propofol, and a narcotic in combination, whether you use remifentanil or fentanyl. And this is a chart that I hope you can take to your anesthesiology colleague with this information. And I think they'll understand it pretty well, why then you are asking for TIVA. We see that the cardiac output with volatile anesthetics leads to really no significant change in cardiac output. And therefore, that's going to harm us, as we know that that's part of the flow, which results in the bleeding. In addition, when it does drop the map, it actually has a reflex tachycardia. So it can result in a higher heart rate, which is also hurting us. And it results in increased cerebral blood flow. Once again, since we're working in the brain, I'm sorry, I hope not, in the nose, we don't want that, because that's going to result in most bleeding for our case. By contrast, if you look below, propofol and remifentanil lower the cardiac output. They either have no change or lower the heart rate, and also decrease cerebral perfusion, meaning that we have less blood in our surgical field. So these are good options for us when we perform our surgery. At least it seems so theoretically. What does the actual data show? Well, in this particular study, they found that when they looked at patients that used sevoflurane versus those that had TIVA. Sevoflurane is this relatively horizontal line, whereas TIVA is this angled line. And they found that there's very little change in the surgical field, regardless of the mean arterial pressure with sevoflurane, as shown by this relatively flat line. But when using TIVA with MAPs of less than 100, the patients had better surgical fields. So it's not just the mean arterial pressure, but it can be the medications you use to get there as well. Finally, IV tranexamic acid. This has been widely used in other fields such as orthopedic surgery. This is a synthetic antifibrinolytic agent that prevents clot from breaking down and therefore may give you a better surgical field. For the most part, the safety profile has been very good as it's been used in many other fields. Of course, there are concerns for thromboembolic complications, and any patient that has a history of those should avoid using this medication. This is used in about 1 gram at induction and possibly at conclusion. Other studies use 15 milligrams per kilogram. Either one should be fine. The systematic reviews demonstrate that it does decrease bleeding and improve your surgical field. So this is a very nice option for patients as well. So I hope today I provided some information to you that you can take to the operative theater with you later today, as I'm headed to here in a few minutes, or next week when you go back to the operating room to discuss with your anesthesiologist, because you need them to help you to get the best field possible. But it's really important to communicate with them because they are not doing these cases all the time and therefore don't know all of our literature. I just want to thank everybody again for allowing me to speak to you today. It's been a real honor to be here. You've got some great lectures, and look forward to seeing you all in person, hopefully in the not so distant future.
Stealth Station ENT, the advanced image guidance system for the full range of navigated ENT procedures. Engineered with you in mind, based on decades of scientific, clinical, and engineering expertise, we're expanding what was previously possible with image-guided surgery. Flexible and elegantly designed, Stealth Station ENT streamlines the workflow so you can maintain focus. The flat, under-the-head emitter allows for an efficient setup. Its design allows for a large EM field. Easily find your patient's exam through a variety of network options, super speed USB or optical disc. The visualization and modeling features give you the perspective you need. Leverage data from multiple sources to create high-resolution 3D images. View structures and pathology with high fidelity. Registration expertly matches the three-dimensional positioning of the patient with the preoperative images used for navigation. Patient registration combines registration methods and provides numerical and visual accuracy feedback. Leverage the latest technology for advanced surgeries. See more, do more. The result? You have an image-guided perspective like never before. With Stealth Station ENT, you're at the forefront of ENT surgery. You are Stealth.
Thank you very much, Phil. That was a great talk. We have a question about oxymetazoline and adrenaline. So there's a question: if they interact, do they have an additive effect or do they have an antagonist effect when they are applied to the mucosa? What's your opinion?
Yeah, there is some theoretical concern that there is some antagonistic, not antagonistic, but that if you use one, that the other one's not going to be quite as beneficial. I've not really found that to be the case. As I kind of said at the beginning, oxymetazoline just doesn't seem to work very well for me. I've not had great luck with it, so I don't use it very much, to be perfectly honest.
Perfect.
But yes, I know about the theoretical blockage, but I haven't found that really to be the case.
And any comment about the topic tranexamic acid? Do you have
Yeah,
any?
there's some research on that too, and it shows some promise as well. There are only so many things I think that we can have in the operating room at a time. IV TXA may be beneficial more so during the surgery when you want to get some clot formation, but before you actually have made any mucosal cuts, it's probably not going to be quite as beneficial as actually getting a little bit of decreased flow into that field with the vasoconstrictors.
Perfect.
I don't know if any of our other illustrious panelists, I see Professor Palmer and I see Professor Woodward here. I see some other very, very intelligent people, so I don't know if they use anything differently.
Hey, this is Jim. Can you guys hear me? Somebody give me a thumbs up. Just a little thing for me. Every year, fellows show up in my OR and say, don't put the oxymetazoline in first and then use epi because it doesn't work pharmacologically, blah, blah, blah. And so then I say, all right, for this week, we will do oxymetazoline on one side and nothing but saline on the other side at the beginning of the case, and I will do that for you. And then we're going to use epi for the rest of the case, and you're going to tell me which side had suffered from the pharmacologic block of oxymetazoline. And they can't ever tell which side. So
I had a feeling you'd have an opinion, Dr. Palmer.
What now?
I had a feeling you'd have an opinion.
Yes, I usually do. Not something that I'm going to bother to try to publish, but year after year I've done that. We do that just to show. And I think it's because while it is true, if you thought the pharmacologic blockade was going to work, it'd be true, except that you put your oxymetazoline, it works locally on the top edges, you get your shrink. And then what you're getting, the benefit from your epinephrine is much deeper than the top layers of tissue because you've worked past that. And so that's why I think it doesn't really matter. If I put oxymetazoline in the middle of the case and then immediately followed with epi in the middle of the case at that same spot, I might not get as much benefit from my epi at that point.
And I see Dr. Woodward also nodding his head. So I think I'm in good company here. It doesn't make a difference.
Okay. Thank you very much. Just to sum up that great summary, Phil, what would you say that are the three more important factors of all the ones you talk about, or that they are a must, that you always try to consider?
TIVA, epi, and I didn't really talk about this, but good surgical technique.
Right.
Suction instruments, I guess, would be my third one.
Perfect. Thank you very much. I think that in interest of time, we will move forward.
Thanks,
Phil.
Be safe.
Thank you, Phil. Thanks, Jim, for joining. I think we are certainly crossing the Atlantic now.